Welcome to my presentation on increasing physical activity among obese African American women in an effort to reduce cardiovascular disease. My name is Jennifer Funk. Obesity is a leading cause of diabetes and cardiovascular disease. According to the American Heart Association, cardiovascular disease kills nearly 50,000 African American women annually. There are specific behavioral risk factors that have been identified that increase an individual's likelihood of developing heart disease. The World Health Organization lists those risk factors to include tobacco use, unhealthy diet and obesity, physical inactivity, and harmful use of alcohol. As you can see on the National Heart, Lung, and Blood Institute infographic, 82.2% of African American women are considered obese or overweight, while only 36% are physically active and 13.6% have diabetes. Research from Peters, Huxley, and Woodward explained that women with diabetes have nearly a 50% greater excess risk of developing fatal cardiovascular heart disease compared with their male counterparts. A study performed by the American Medical Association revealed that African American women had the highest rates of obesity, meaning a BMI greater than 30. Thomas reported in 2009 that 67.3% of African American women qualify as overweight or obese. Joseph reported in 2017 that national data revealed that 57% of African American are obese, with 48.3% of all African American women in the U.S. having cardiovascular disease, compared to 31.9% of white women and 32.5% of Hispanic women. So why is this demographic not exercising? African American women are more likely to experience cultural pressure to be self-accepting of their physical shape, regardless of size. Inactivity determinants identified by King include lack of time due to caregiver responsibilities, health concerns, and lack of motivation to be physically active during leisure time. Safety of the surrounding environment, availability of appropriate programs, and cost issues were noted to be barriers to physical activity among minority women more than 40 years of age. So let's look at some health behavior theories. The trans-theoretical model is the most popular model for studying physical activity behavior. This model can contribute to the classification of people and help them change and maintain their behavior by applying different strategies and processes suitable for each stage. Curriculum for behavior change is then developed to target specific cognitive and behavioral strategies based on the stages of change. The stages of change model acknowledges that behavioral change requires time and motivation for activation of processes of change that enable individuals to move through stages of change, noting that the stages reflect levels of motivational readiness or intentions to change or modify a behavior, and consists of a continuum from not intending to change to the maintenance of a behavior. Various other theories have been used to design behavioral health modifications. From a health belief model perspective, African American women report a limitation of modifying behaviors. When asked about the possibility of changing food present in the home, if there were children living in the home, this was not a behavior they felt they could modify. African American women tend to prioritize the needs of peer and extended family networks over independent, self-determined goal setting. When looking at the constructs of the protection motivation theory, research has shown that fear is not a motivator for behavior change in this culture. The lack of ability to identify risk factors for heart disease is high in this population, thereby creating a group of women that believe heart disease won't affect them, since the connection between their behavior and the outcome risks are not clearly understood. Based on the understanding of the extended parallel process model, fear appeal cannot be successful because it does not increase a sense of perceived threat or a sense of efficacy to successfully engage in a recommendation within this culture. A useful theory in physical activity promotion research is social cognitive theory, which explains behavior in a dynamic and reciprocal model in which personal factors such as beliefs and attitudes, the environment, both social and physical, and the behavior itself interact to produce a behavior. In a study of existing research, overweight and obesity was the most common type of health condition addressed by social cognitive theory interventions. Annecy proposed that social cognitive theory posits a triadic reciprocal relationship between person, environment, and behavior, and suggests that individuals receive reinforcement value by connecting the behaviors, such as physical activity, to valued outcomes, like the perception of a more attractive body or improved mood. So why aren't current interventions successful in decreasing the obesity rate in African American women? The noted downfall of current behavior interventions is their lack of sustained change or maintenance. This lack of sustained change leads to a pattern of weight loss and then gain, the yo-yo effect, as each new approach to weight loss is attempted by individuals. Another influencing factor is the individual's belief regarding the perceived downside of not changing a behavior. If the perceived benefit of changing the behavior does not outweigh the benefits of the behavior, no change will occur. Inappropriate expectations lead to a lack of sustainability as well. If women feel they should lose weight faster than they are, or that someone else is losing more weight, the motivation to continue diminishes. Programs that assume participants are motivated to lose weight in order to feel more attractive or use independent goal setting as the primary charge strategy might not be aligned with cultural perspectives of African Americans. A proposed intervention to increase physical activity among African American women in an effort to decrease cardiovascular disease would utilize both the social cognitive theory and the trans-theoretical model. It would include education on the effects of obesity on cardiovascular health, as well as simple, realistic options for increasing physical activity in an effort to increase perceived vulnerability and self-efficacy. The intervention must include the involvement of social support systems. This can include identifying someone that is significant to the individual, or by creating a group that participates and increases physical activity together, forming a support group. How the intervention is rolled out is dependent on how the individual can be classified in a stage. Someone who is in pre-contemplation will need more time and reinforcement in the educational portion of the intervention, whereby someone in the contemplation or action stage may move quickly through the education and directly into the implementation phase. There must be an aspect of fluidity to how individuals flow through the intervention. Moving all individuals through the process at the same rate will not be effective, leading to frustration for those struggling to act or to maintain. Potential issues that may arise involve cost and availability. If the program is cost prohibitive, it clearly defeats the purpose. The location and frequency of the program is also impactful. If only a few opportunities are provided, or if it is only provided in affluent communities or rural areas, this would preclude portions of the population from participating. Cardiovascular disease is a leading killer among women, but by controlling weight and obesity in a population with the highest proclivity, the risk of occurrence can be dramatically reduced. Thank you for listening to my presentation, and if you have interest in learning more, please refer to the references listed.